Good morning, everybody. My name is Stephen. I'm a Master of Medical Physics student, and this is my proposal presentation for predictive machine learning for dialysis modality transitions using remote monitoring data. And yeah, I'd just like to give a big thanks to my supervisors, Veteran Neil and Jake. So just starting off with a little bit of background for the patients we're going to be looking at. These patients are going to be affected by chronic kidney disease, which is a disease that affects the kidney's function and currently makes up for 1.1% of the total disease burden in Australia, at least as of 2024. Patients who suffer from this and have worsened kidney function up to a certain point that reaches kidney failure, where their kidneys are inadequate to be able to filter their blood, will require kidney replacement therapy. So kidney replacement therapy has two main modalities, which is either dialysis or kidney transplantation. In terms of kidney transplantation, has a survival advantage and arguably better overall quality of life treatment, but not all patients are suitable for it. And obviously there aren't always kidneys to go around for patients. So the other patients are left with dialysis, which uses dialysate to allow waste filtration from the blood. There are two main modalities of dialysis: peritoneal dialysis, which is a home care modality, and hemodialysis, which is mainly an in-clinic modality. And my project will be to do with predicting the transition of some patients that will need to transition from PD to HD. And just a quick overview of our anatomy, hopefully you remember some of it. Just how the kidneys will filter blood. The blood will go through the Bowman's capsule, the glomerulus, where the blood will then be separated to its solutes and waters. Solutes and water will then flow through. Some of it will be filtered back into our body, and the waste will be filtered out through the urine. The patients on kidney replacement therapy, of course, their kidneys aren't able to do this adequately. So for peritoneal dialysis, what it looks like for them is the dialysate will go through the solution bag and through a catheter that's inserted into their peritoneum. The dialysate will then rest in their peritoneal cavity, where it will exchange fluids with the blood outside of the peritoneal membrane. That will actually allow it to filter the waste through the blood. Then the dialysate will then be picked up by the catheter and transferred into the drainage bag. So that's for peritoneal dialysis patients. A little different for hemodialysis. The difference is mainly there's an arteriovenous graft created in the wrist. This will allow blood to be removed for dialysis and sent to a dialyzer filter, which will include dialysate, which will be able to filter the blood, and then filtered blood will then be able to be returned to the body. So just background on what the modality transition is really between PD and HD. So this involves PD technique failure. In Australia, we only define PD technique failure for patients who have already had 90 days of PD, and to the point where they cease PD, transition to HD for 30 or more days. That's what we call it transition from PD to HD, so the transition of their modalities. The main cause of PD technique failure is peritonitis, which is repeated infection of the peritoneum. As I've said before, the catheters insert through the peritoneum. Sometimes patients can get infections, and that'll affect their peritoneal membrane, which will affect the adequacy of filtration. We're lucky enough to be able to utilize the ANZ data registry, which is a large-scale data set for kidney replacement therapy patients across Australia and New Zealand. So it's got a lot of years in the making. It's going to have a lot of demographics and laboratory data, alerts, and biomarkers. And specifically, we're going to be using remote patient monitoring data. This has been around for a few decades. It allows virtual monitoring and assessment of patients' health, but really it's been picked up a lot more since COVID. So we'll be able to see the effect that'll have on our predictions. Remote patient monitoring will involve time series treatment data. So pretty much data from dialysis sessions, seeing how much was like the volumes of filtration they had and everything like that. Currently, the state of the literature for PD technique failure prediction. There have been a few models. These are the two with the greatest performance that I found in my literature review, using the LSTM model and a random forest model. However, all the technique failure prediction models that I've seen in my literature review, they all work on patient PD cohorts with less than 1,000, and most of them didn't include any external validation. So that's a bit of a gap in literature. The good thing about what we're able to do with the ANZ data registry is we're going to have a massive, well, hopefully, quite massive, large scale number of patients. So we'll be able to deal with the larger cohort and see how our predictions will function on those. And from what I've also seen in other terms of in other dialysis patient predictions, for instance, in major adverse cardiovascular events and mortality predictions, random forest, XGBoost, and other ensemble methods, RNNs, and LSTM models achieved consistently high results. So I'll definitely be looking forward to implementing some of these ones in my research. And yet the significance in the research lies in its potential for early identification of at-risk PD patients, reduce complications and enhance patient quality of life, optimize allocation of HD chair resources, and reduce the clinical burden with assisted risk assessments, as well as it being the first machine learning study for PD patients, combining ANZ data and RPM data. So we'll be able to see how the RPM data might actually affect our predictions, and we'll also be able to create a reproducible pipeline for future predictions for PD patients. The current workflow in nephrology for the transition of PD patients to HD patients is ascertaining the patient's time on PD, assessing other indicators of PD technique failure. So if the patients have one or more indications of failure can be things like peritonitis or other ways of seeing how filtration is inadequate. Then this will be discussed with the nephrologist for remedial actions. And if a patient responds negatively to remedial actions, a care management plan might be made, and they may transfer to HD. So really the AI comes in here between those first and third step, really with the assessment of indicators of PD technique failure, being able to assist with clinical review and risk stratification of patients. Getting into the main aims of our project. So the first aim will be to develop and evaluate predictive performance of supervised machine learning models to predict PD to HD modality transition using RPM data from the ANZ data registry. And the second aim will be to investigate interpretability and explainability of the best performing models using explainable AI techniques like SHAP and assessing their clinical relevance and the efficacy of RPM data in risk stratification. So involved in aim one would be the cohort selection. So there may be missingness, we're not too sure on the terms of the missingness of the data. It's going to be entered by some patients and some clinicians. So taking a little bit of inspiration from one of the papers I've seen for mortality prediction for patients initiating dialysis, they had a patient cohort of over 1 million patients, and they removed patient data that had greater than 40% missingness, and that's the C statistic they achieved on non-imputed data. So we still might undergo some data imputation for hours, possibly using just means and medians for missing data. And of course, making sure we have an inclusion criteria for the cohort selection. It'll be adult PD patients on PD for greater than 90 days. And just knowing the outcome will be transfer to HD for 30 days or more. During our aim one, it's also going to involve feature engineering. So we're going to have all these types of data, time series data, lab values, comorbidities. So one thing we're definitely going to want to use is temporal aggregation using slopes and gradients, rolling STDs and means, checking the variability of different data points. For instance, blood pressure. Maybe we really just want to see the variability of the blood pressure rather than mean values or anything like that, but it depends on each data point. And encoding comorbidities and covariates. And of course, one part encoding the target from PD to HD transfer. Our process is also going to involve model development. So for baseline models, we might use logistic regression and decision trees, followed by RF, XGBoost, and other ensemble methods. As we've seen in the literature, these have produced pretty good results. So I'm looking forward to using some of these. And we'll also get into using some deep learning methods as well. Currently, I'm not so experienced with deep learning, but I'll be doing my deep learning unit and be able to use some of these on our data set. Going to be using temporal validation, so we're going to focus on time splits, considering we're doing patient predictions within the next 12 months based on past patient data. And it's going to involve high parameter tuning, of course. Computational expense would be a challenge, but due to it being a large scale data set with high dimensionality, but I'm sure the computers here at Charlie should be good enough to handle that. And we're of course also going to include our evaluation framework. So we're going to be using OROC and area under the precision recall curve, and sensitivity, specificity, and area score, just to assess our models and see how well they do. In terms of aim 2, our main focus is to investigate model interpretability. So this is going to involve us using Shapley additive explanations. This allows us to see rank feature importance across populations, dependence plots highlighting how features interact with each other, and identifying clinical drivers for PD to HD transition risk. And this here is a feature importance plot from Stru et al. In 2024. They were predicting technique failure for PD patients. And we're also going to use other explainable AI techniques, such as LIME. This allows rank feature importance, but only for specific patient predictions. So even though Shapley is quite stable, and LIME is arguably less stable than SHAP, we still might use something like LIME just because SHAP can have its drawbacks in terms of categorical feature importance, I believe it is. Sorry, for categorical variables, feature importance. So we still might use a combination of explainable AI tools. And our other parts for aim 2 will be to assess and report the alignment of values with established clinical knowledge for key predictors. Assess and report the efficacy of the RP and data contribution. And if possible, do a usability evaluation with nephrologists. In terms of our timeline, so we'll be acquiring ethics from HRDC and getting the data transferred to UWA. After that, we'll begin the cohort selection and then into feature engineering, developing machine learning models, evaluation feature analysis, then developing DL models, evaluation feature analysis, and investigation into the features. Depending on the amount of time this takes, we've discussed with Neil, we might actually explore other outcomes as well. Outcomes such as, I think, peritonitis, just predicting peritonitis for PD patients, predicting mortality, predicting which patients from the ANZ data registry might be able to be suitable for kidney transplantations. That is a bit ambitious for now, though, so I'm not going to commit to that yet. We'll just see how this pipeline goes and hopefully we can explore more outcomes. And yeah, that's the general timeline in terms of the upcoming months. And of course, writing the thesis will be that final part at the end. So exciting. Very well done. Any questions?
Hopefully, it's a very clear presentation. Just a bit of clarification. I think the timeline of this is acquire HREC. Have you guys already acquired HREC or still in the process of acquiring HREC?
I think we're still in the process of buying.
Oh, okay. Just slightly worried about the timeline.
Yeah.
Your masters, we have to wait very long for that.
But they're already approval.
Already approval. Okay, that's great. I guess second question is, I think you only mentioned temporal split for validation.
Yeah.
I'm just wondering, I guess since your data set is very great,
yeah,
to have different centers, is it potentially to have an entire center to as a whole dog test set so you can do a proper external validation?
Yeah, that would be a good idea. I've seen that being used in the literature as well. Yeah, to be honest, I should have included that. Yeah, I think we should.
That's usually like more recommended than temporal split if it's possible.
Okay, yeah.
To do something like that.
Yeah, that's a good idea. Yeah, thank you.
It's all the questions that people.
Yeah, thank you.
When you look at time series, you look at it as different time scales, or it may be possible to do the frequency domain conversion, look at like kappa in the signal.
Yeah, yeah, perhaps. I think that yeah, Yeah, for sure. We can the frequency domains as well. I think from the literature, a lot of it was time averaging, like just across months. Especially for the more basic machine learning models. In terms of using the deep learning models, I'd definitely be interested in things like that. But, yeah. Anything else?
So Stephen, I just wanted to get your thoughts on what you thought about how you would compare the AI models that you're trained. So what sort of process do you think you would follow? For example, say that the next cheapest is better than a random forest.
Yeah, I think mainly the comparison would be through the evaluation framework, as well as also assessing like fictional usage and how stable the results are, how consistent they are.
Yeah.
But yeah.
And I guess a long question from that would be how would you split the data to do that comparison? Do you have an idea of how you split the data to do that comparison?
Yeah, in terms of like just a training test, sorry, a training set and about a test set, just like an 80-20 split.
Okay.
Standard.
I think probably the best way to do it would be a cross-validation framework. So you models on the part of the data and you reserve a test set. So you're only selecting models on data that you've trained on. But that's something to discuss later.
Yeah, we can discuss later because your hyperparameter tuning is always going to be paired with something like cross-validation.
Yeah, okay, yeah. Excellent. Thanks.
Anybody, any questions online? No questions online? Over. Very good, clear presentation.
Thanks, Stephen. Well done.